Well, hello there. Just want to go over some information with you guys to finish like the first set of PowerPoints we have here. One of the things that people talk about on occasions is direct cardiac compression. That's basically opening your chest, okay? This is only done in emergency situations. It's not something that we're going to do all the time. As you can see, it's not a last-ditch effort. Um, if you have your chest already open, then perhaps they could try it, but that's about it. Because you're actually compressing the heart at this particular point in time, you're getting near normal perfusion. There is the rate of 60 to 80 compressions per minute. And then the problem is, though, is because you are compressing the heart, there's going to be some morbidity and possibly some mortality as a result of it. Anyways, they would have to sacrifice like 50,000 people a day to the gods of harvest and sun and snow and rain and things like that. And the question is how were they able to do that? Well, they said, well, they did it in various parts of their territory. But what they found out is that by going through the diaphragm, you could pull the heart out within a very short period of time. Seconds is all it took. And that's how they were able to sacrifice 50,000 people every day when they needed to. So you may or may not ever see mask trousers. If they're going to use them, they're going to use them for patients who are pretty far away from hospitals and everything. They're up to good for about 2 hours. You have to make sure that when you put them on, you understand what you're doing, because what you're going to do is you're going to take and force the fluid out of the lower extremities up into the inner thoracic cavity. As you can see, it exerts pressures up to 120 millimeters of mercury around the lower extremities at that particular point in time. When you take these off, you have to be careful, otherwise your patient's going to go into shock. And this actually happened to a commuter who was standing waiting for a subway train up in New York. Somehow he got pushed between the train and the station where he was standing, and when he did, the train sort of just spun his lower portion of his body around, and they went and had to go get his family so he could say goodbye to them, because they knew as soon as they let the car or move the car away from him that he was going to actually end up dying, and that's exactly what happened to him. Only contraindication, pulmonary edema, because you already have a bunch of fluid. We just can't put more fluid up there at that particular point. Stroke is one of those things that kills a lot of folks. And you don't have to be old to have strokes. You can be a baby and have a stroke. You can be a young person, even before preteens and things like that, you can have a stroke. So people think strokes happen to old folks, but that's not true. Some will tell you that someone will suffer a stroke every 40 seconds. Someone dies from a stroke every 4 minutes. By 2050, we figure 1 million Americans will suffer strokes annually. It's estimated that 7 million stroke survivors in the U.S. are over age 20. And the direct and indirect cost of these in 2010 was $73.7 billion, okay? As you can see, it's a leading cause of death in the U.S. It goes up to second, third, fourth place, just depends on what we're looking at that particular point. It kills approximately 133,000 per year, and a lot of these folks who die because they've had a previous stroke, okay? And as you can see, there's again, doesn't matter who it is, doesn't matter respect age, race, or anything else. So how do we counteract this? You need to educate people that strokes are not things that you just take lightly. If you suspect someone's having a stroke, you need to call 911. And then you have to get them to the hospital, and there's going to be a rapid triage and evaluation. There's also a standard that has to be met. And every year, hospitals are graded on these standards and how quickly they can react to what's going on. It is a medical emergency, so how do I know that someone's having a stroke? Some things that we see: sudden onset of numbness or weakness in the face, arm or leg, especially one side. What's interesting, if you have Bell's palsies, that actually affects one half of the face also. So, is it Bell's palsy or is it a stroke? You still need to get help, okay? Sudden confusion, having problems speaking or understanding what's going on. You're trying to talk to these folks. They either can't talk to you and make any sounds, or if they're talking to you, it's like blue card, green, whatever, and you're going, that's not quite the question I asked, but they think and they can hear in their minds that that is they're answering your question. Double vision, blurry vision, partial blindness, as you can see, sudden onset of dizziness, trouble walking. People will walk into walls and they have to hold on to the walls to make sure that they're supporting themselves. And something about the head, and I'm going to tell you this because when we talk about head trauma, we're going to talk about this also. If you have a severe, sudden, unexplained headache, the worst headache you've ever had, it's your migraine times 2, your migraine times 5. You need to get help because something is going on in the head. So how do we classify strokes? Well, there's a couple of classifications. One is your TIA, transient ischemic attack. This is the mini stroke. This is one where most people recover a lot of stuff that they may have lost. They can speak again. You may not see any evidence of this if you do an MRI or a CT or anything like that. The problem with the TIA is that basically it sets you up for another stroke, a worse stroke, as a matter of fact. The ischemic stroke is the major one. As you can see, about 87% of the people who have strokes have ischemic strokes, and these are a complete occlusion of an artery. It can be from a thrombus or an emboli at this particular point, okay? And hypertension is actually the most common cause of intracerebral hemorrhaging. Hemorrhagic is about 13%, and it's a rupture of the artery. Sometimes you don't even know that you have this problem until the artery ruptures at this particular point. One thing you want to remember is there's a lot of blood vessels and a lot of blood in the brain, so there's a lot of it that's going to go ahead and be released at that point. And so you're going to see some bleeding into the brain parenchyma, and that's your intracerebral strokes. And this just shows you a little bit about what happens. Your cardiac buoy, for the most part, will tell you there's a partial obstruction of the artery, and it's associated with increased risk of a stroke. Things you cannot change, the same as with cardiac disease, your age, heredity, gender, race, and whether or not you've had a prior stroke, okay? So the thing to remember with this, the bottom line, if the patient is or person is acting kind of strange and they're bumping into walls or they can't see or they can't talk or they're talking and they're not understandable, there could be a possibility of a stroke. You need to call 911 immediately, okay? And one of the things that they'll tell you is that 2 million brain cells die every minute during a stroke, and this increases permanent brain damage, disability, or death, okay? A quarter of your stroke victims are under 55 years of age. Like I said, it can affect anyone at any time. So what do? First of all, if you think someone's having a stroke, call 911. Get them to the hospital. They're going to go ahead and do the different tests, the fast test, to see whether or not this person is having a stroke, okay? We're going to make sure that we deliver them to the hospital, get all the information we can, make a decision, and if we are going to give drugs, give drugs. Now, TPA, which is tissue plasma activator, that was one of the drugs in the previous PowerPoint, can be given now up to 4.5 hours from the beginning of the stroke, okay? It used to be 3, but now they've actually upped it to about 4.5 hours. But one thing you need to watch for is you're not on another blood thinner if they give you TPA. If they do, what's going to happen is you're going to bleed out. So it's really important to make sure that if you or anybody in your family is on a blood thinner, that you make sure everybody knows that. Carry a card with all your medications on it. Have it available in case you do have to go to the hospital. It's much, much better for you. And I'm sure almost everybody in the U.S. has probably choked once or twice on something, okay? Some of the times these symptoms can be very minor and missed. Other times they're life-threatening and they can actually cause you to die. We don't lose a lot of folks, as you can see, about 3,000 deaths per year before anybody gets evaluated. In the U.S., most of the choking victims are males. Females are the common choking victims outside of the U.S., okay? Most of them are going to end up in the right mainstem and in the lower lobe. If you look at these, you can see children from 1 to 3 years. If you have kids or nephews or nieces or these guys are up and around and running, putting everything in their mouth, and unfortunately, sometimes they will end up choking on them. With the elderly, which I also call the people of age, sometimes, especially if they have some dementia, Alzheimer's, they can become what we call silent chokers. And what happens to them is they can't tell you that they're choking. And so what happens is a lot of times if you look at them, you'll see they're almost crying because they can't swallow and they're starting to choke on the food that's being fed to them. So you always have to keep an eye on them too. If you do bronchs or anything like that, one of the things we do is numb up the airway. We always need to tell folks you cannot eat after a bronch procedure until you're able to swallow and know that you've swallowed something. So you really got to be careful with that. And then neurological or psychiatric disorders will have something that goes with it too at that point. Now, what are some of the most common things that people choke on? Grapes, hot dogs, and peanuts. Peanuts are the most commonly aspirated food. And this is just the American Heart Association guideline for an adult foreign body airway obstruction treatment. As you can see, they've divided into severe and then mild. Mild, you're going to monitor these folks as long as they have this effective cough and everything. If they're able to continue to cough it out and then finally do cough it out, then, if they need to call 911, you can do it at that point. But you just monitor to make sure to see what's happening with them. Severe, if they're conscious, 5 back blows, 5 abdominal thrust. Unconscious, start CPR at that point. So as you can see, there's just a couple of kinds of airway obstruction. Mild, the patient or person can still talk to you. They have a cough, able to remove whatever the obstruction is and do well by themselves. Severe is when they can't. It's the exact opposite, okay? Some of the pearls and pitfalls of foreign body obstructions are a normal chest x-ray does not necessarily rule out that you do not have a foreign body obstruction, because sometimes whatever it is you aspirated will hide behind other organs in your chest cavity. And they've found this to be true because they found people who've had pennies and peanuts and whatever else in their lungs for years and years, causing them difficulty. But finally, something happened. They took an x-ray and there it was at that particular point. The other thing is not everything that wheezes is asthma. We have what they call cardiac wheezing, but this has to do with a cardiac issue. And the same with foreign body aspirations. That will sometimes also cause you to wheeze, okay? And you can practice if there's duplicate things that you can see what happens when people aspirate, and be ready and equipped to take care of it. And then don't make a closed case an open one. If you're taking care of it, make sure you take it care, okay? And don't turn that obstruction into something that was non-obstructing into an obstruction one, okay? And then the last thing is, don't think there's only one object. There could be more than one, so always be prepared to take a look. So there it is. Coughing or choking occurs in about 95% of the cases. It progresses to respiratory distress, inspiratory stridor, expiratory wheezing. You can see tachypnea, nasal flaring, intercostal retractions, and there's the inability to speak. They have cyanosis, they're confused, and then they can become unconscious. And remember that you always want to put them over your legs so that if they do go unconscious, you can slide them to the floor. You don't have to drop them and bounce their heads off the linoleum. Complete foreign body airway obstruction. Your patient's now unconscious. Activate the EMS and then perform your CABs. Okay, so there it is. Good one. Are you choking? We're just going to monitor you. One that's bad is things are getting worse. Prepare to intervene. Heimlich maneuver at that particular point. Dr. Heimlich, by the way, was able to use his maneuver when he was living in a nursing home before he died. And that was the first time he had a chance to do it. And there you see for pregnant or obese victims, you're going to use chest thrust instead. And there you see things that you talked about. Adults, the Heimlich maneuver, back blows, whatever, chest thrust. Children over 1 year of age, a series of 5 abdominal thrusts. Okay. Under 1 year of age, a combination of 5 back blows with the flat of the hand, and then 5 abdominal thrusts with 2 fingers on the upper abdomen. So complete obstruction, lambs supine, call for help. You can look and see if there's something in there. Try to open the airway, try to give rescue breaths, and if you need to, go ahead and start your CPR. This tells you a little bit about it too. So here's the pediatric choking algorithm, sort of very similar to that of an adult, but just be aware of it, okay? So modes of transportation. How many of you guys want to be a flight therapist? You talked to Trish. She was a flight therapist for, I guess, a couple of years. There's some folks at TMC that still do it also. There's 2 modes of transportation. One is your helicopter. If you remember, if you ever watched MASH back in the 80s, 90s, they used to take the victims in the Korean War to the MASH units. That's where they were taken care of before they were transported. And then you would have your fixed wing aircraft that allowed you to do those. And your fixed wing are, for the most part, lengthy transports, and they take you from the small MASH unit to a bigger hospital. Some of the first transportation was actually done up in Denver, but St. Anthony's Hospital was like 1972, and that's when they got together, and that's where this started. So just different things. Cabin pressure. This is your pressure that we're trying to keep a little bit closer to the Earth's barometric pressure as you go up. As you can see, anything above 10,000 feet, you have to have oxygen at that particular point in time. Cabin differential pressure, difference between what's outside the aircraft, what's inside the aircraft, and it varies as you move the aircraft up or down. That pressure will vary. Decompression is a loss of this cabin pressure. It can go anywhere from seconds to minutes. It can pull you through a little hole. It can pull you through a window, as a matter of fact. So what happens if you do have rapid decompression? As you can see, especially if you're high, hypoxia, hypothermia, gas expansion, and then go into decompression illness at that particular point. And then you have 2 aircraft pressurization system. One is isobaric. You can see that's your jet airliner. And then you have the isobaric differential system. These are your tactical aircraft. So they wanted to know what happened when you flew, okay? And they went to the Air Force, and the Air Force said, here's 8 classical stresses of flight. One is decreased partial pressure of oxygen, barometric pressure changes, thermal changes. You guys know as you go up in altitude, it gets very, very cold, okay? Decreased humidity, because it's also very, very dry at that particular point. Noise is another one, vibration, fatigue, and G-forces. And so there's a partial pressure of oxygen, and this is a famous law that you probably want to review if you haven't. There's 4 stages. One is the indifferent stage where, it's not a big deal. Compensatory stage above 10,000 feet. Your heart rate's up a little bit. Your breathing's up just a little bit. Sometimes you don't even know it, that this is what's going on. Disturbance stage, that's above 15,000 feet. Now you know what's going on because you can feel yourself breathing faster and your heart's beating faster at that particular point. Once you get to the critical stage, this is where you have a good chance of passing out. It doesn't take very long for that to happen. Thermal changes is there. You can see as you go up, it gets much colder up there. And this is just some information for you if you're looking for something to play Trivial Pursuit with, okay? And what happens is, as you can see, vibration, thermal changes, turbulence, all affects the body. And, you know, if you're very cold or very hot, you're normally very uncomfortable too. Decreased humidity. All of you guys have flown know it's very dry. What do? They come around, they offer you a mixed drink or something like that. And you go, alcohol, that sounds good. Alcohol is also very drying, so you do have to be careful with that. It's better to drink water or eat the ice cubes and just leave whatever is kind of drying behind. Okay. If you're working with a patient, you need to make sure that you provide humidity to those patients because they're going to be extremely dry also. Fatigue. I love this slide because it explains so much for people who don't realize this. All stresses of flight include fatigue. And any type of major stress you're having on the terra firma is also going to have fatigue. And you guys have probably noticed that or not understood why, if you've been through an extremely stressful situation, that you're going, wow, this is over. And then you sit down and you're about ready to fall asleep at that point. Vibration, you can, if you've flown, you know that the plane is moving and just depends on what you're going over at that particular point. Sometimes can be very uncomfortable, especially if you're up when you're supposed to be down and you travel upward and hit the ceiling of the plane. Gravitational forces, this is acceleration, deceleration. We need to position the patient so they're comfortable. A lot of times you'll go ahead and you'll turn the patient to be backwards. Okay, remember when you're sitting, a lot of times you're facing the front towards the cockpit. Well, we can flip you around so now you're facing the back of the plane. And sometimes sitting that way is more comfortable too, okay? Noise is another one. Very unpleasant, unwanted, distracting, undesirable. This is when somebody is playing a loud rap band while you're sitting in your car and your car's bouncing all over the road. That is vibration and noise, okay? Remember, noises are measured as decibels, okay? And as you can see, ambient noise level 80 to 85, you have to shout to be heard at this particular point. Normal conversation is about 60 decibels. If they're using the jackhammers, like you've seen or may have been around, that's like 105 decibels. And here's Mr. Boyle. Remember his law at that point? Volume varies inversely to pressure. So as you're going up, gas expands. As you descend, the gas contracts. This is why, and you'll see this a little bit further down too, when you're getting ready to fly, you don't want to be chewing gum. You don't want to have the jalapeno poppers that you thought were really good are going to be very uncomfortable as you ascend at that particular point in time. Okay, and as you can see, you can sometimes have these gases trapped in your GI tract, ears, sinuses, lungs, skull, teeth, anything that has an opening to it, you're going to see that at that point. And sometimes you can find out that you get tooth problems and that they are, in fact, tooth problems and not sinus problems laying down on your teeth. The other thing is your middle ear is connected to the nasal pharynx by the eustachian tube, and you have to go ahead and try to equalize it. Most of the time it's very passive. You can just sort of yawn or do something like that. However, when you're coming down, you have to make sure that you open it up. And there's parotitis media, okay? And this is the failure of your middle ear to ventilate at this particular point. And so as you can see with it, you're going to get a partial vacuum and you're going to pull the tympanic membrane inward. It's going to become inflamed, develop petechial hemorrhages. Petechial hemorrhages are kind of interesting because they're very small, tiny hemorrhages at this particular point. Here's your barosinusitis, and this is your sinus block. If you have a sinus congestion and a sinus block, you may want to consider driving and not flying, because if your sinuses rupture, you're right next to your brain, and that's where a lot of that stuff is going to end up. So you don't want to do that. Now, people will tell you, well, you can go buy Afrin, that'll work, and yeah, it does work. It works for, if you buy the right kind, for about 12 hours. At the end of 12 hours, if you're still flying on one of these flights between here and Australia or someplace like that, you're going to probably have to use it again. And you guys also know that if you're going to use Afrin, you can only use it for 3 days. Most people use it and they'll use it for years and years, and they're like, man, this is the best stuff in the world. It always opens my nose up, until it doesn't work. And then you have a rebound effect on your sinus pressure and on your sinus congestion at that point. And barodontologia, okay? This is, you go up, you have problems with your teeth, okay? And it can be a problem with your teeth directly, and this is moderate to severe pain. Otherwise, in some cases, and especially maxillary teeth, it could be something else laying on them, like your sinuses. If your sinuses are swollen, they'll actually press down on your teeth. GI changes are always comforting to know. Your GI system saturated with water, okay, cannot compress, which makes sense, okay. Wet gas expansion will expand more than dry gases. On ascent, it's 1.5 times what you would have at sea level, okay? And what happens is, if you don't get relief at this particular point, you can drop your blood pressure and go into shock or have syncope at that particular point, passing out. So if you're going to be a therapist who's going to fly, you need to know about your transport equipment, tanks or liquid, the suction machine. All of these different things are made for the plane or for the flight. And part of your job is going to go around, make sure that they're there and that they're secured appropriately and that they're actually working. And pulmonary edema, one of the things you want to think about with pulmonary edema, practically everything that can happen to you can cause pulmonary edema. It can be cardiogenic, non-cardiogenic. The new terms are hydrostatic and non-hydrostatic. So cardiogenic is hydrostatic, non-cardiogenic is non-hydrostatic, okay? It is potentially life-threatening. How do you breathe when you have fluid in your alveoli? You are not going to have any gas exchange at that particular point, okay? So with transudates, and you guys should know what the definition of a transudate. It increases your pulmonary capillary pressure, and it also increases the permeability of the capillary alveolar barrier. And basically, these are some of the pathophysiology of acute pulmonary edema. Here's this one is like myocardial infarction. As you can see, problems with the heart. The heart's not going to pump very well, and when it doesn't, the fluid's going to build up. And as it builds up, it's got to leave because there's only so much room where you can hold fluid. So some of the causes of pulmonary edema, some of the cardiac causes, left ventricle failure, mitral valve disease, renal disease is another one that's kind of an interesting one. Diseases of the pulmonary vein, fluid overload that you get with cirrhosis. Then you also have some neurogenic causes such as head trauma, increased ICP, are part of them. And then non-cardiac causes that you have aspiration of noxious fluids, ingestion of drugs or poisons, inhalation of fluids that you're not supposed to be inhaling, pulmonary infections, systemic sepsis. We're going to talk about that when we talk about shock. And then trauma will cause it too. Matter of fact, almost everything we're going to talk about causes pulmonary edema. And so there's the two types that you can see, cardiogenic for the most part, pulmonary capillary wedge pressure caused by left-sided heart failure, fluid overload. You're going to see this on your EKG. You're going to see it on the electrocardiograms that you do, and a large cardiac silhouette on the chest x-ray because of the fluid that's surrounding the cardiac cavity. And this was kind of a cool picture, as you can see the difference between cardiogenic pulmonary edema and non-cardiac or non-cardiogenic pulmonary edema. And if you can memorize this, it's okay, you don't have to. This is another one. This is a left typical feature of cardiogenic pulmonary edema. There's this smooth septal thickening, some ground glass opacities in the dependent part of the lungs. You can see the vessels are pretty easy to see. They're pretty well infiltrated with fluid at this particular point. And you could do measurements of the plasma BNP, which is your brain neurotic pressures, okay? And that'll tell you what's going on with your pulmonary edema. It's a really rapid test they sometimes use in the emergency departments at this particular point. So here's 2 CT scans. You can see on the one over figure 3 that that's the classic bat wing pattern, okay? And it's the very diagnostic of pulmonary edema. On some of the new board exams that you have, they're not saying what is the classic pattern of pulmonary edema. They're going to tell you, here's a classic pattern. It's a bat wing. What is your x-ray? Okay. And then on 2, you can see the hazy pattern of the central hilar area. So lots and lots of fluid at that particular point. And you can see with this one, lots of fluid. Non-cardiogenic, this is altered capillary permeability. Most common cause is ARDS. We're going to spend a lot of time in 4th semester talking about ARDS. And like I said, almost everything we're going to talk about causes pulmonary edema. Drowning, poisoning, smoke inhalation, fluid overload, shock, toxic damage, high altitude, the whole 9 yards. So don't be surprised to see pulmonary edema coming up. So how do we know that somebody has it? Well, first of all, it's very difficult breathing. A lot of times these guys want to lay down. You don't want them laying down. You want to sit them up, because if you lay down, the fluid's going into their lungs and occupy the entire lungs. They're going to be tachycardic. They're going to be hypertensive. Pink frothy sputum is not initially a lot of times what you see. Sometimes you're going to see white frothy sputum. The blood has to mix with the fluid in order to produce the pink sputum. And so sometimes you'll see that white before you ever get to the pink. Some crackles too. Where do we hear most of these crackles? If the patients are sitting upright, you're going to hear them at the bases. They're late inspiratory crackles, very fine crackles too at that point. So when on the side of patient assessment, always make sure you listen to inspiration, expiration, because they're very late inspiratory crackles. And then you're going to have decreased peripheral perfusion because there's nothing to put out. So what do we do? Besides the BNP, we can do your CBC, complete blood count, your BUN, which is blood and urea and nitrogen, creatinine levels. We're going to talk about serum proteins when in advanced patient assessment, along with the CBC, BUN, and creatinine. Your analysis will tell us this. Your ABG will tell us this. Chest X-ray and your ECG will also give that to us. And how are we going to treat this? Basically, we're going to go ahead and give you 100% oxygen because you need it. Morphine is really good because it relaxes the vasculature. And when it relaxes the vasculature, it also eases your anxiety. So it's really good as far as that goes. However, you don't want these people standing in the middle of the room because they're probably going to end up on the floor. Lasix to diurese, Fowler's position, and then digitalis, dopamine, and dobutamine, okay? These are going to help with your vasculature, okay? Remember, dopamine and dobutamine we use on patients with really, really bad blood pressures, and so we're going to use them with these guys too. Nitrocrucide reduces the afterload, making it easier to pump the blood out of the heart at that particular point. Let me see if we can get our system going again. These are also patients that you can use with CPAP, BiPAP, as long as they're not in really dire straits. Sometimes we do have to put you on mechanical ventilation. One of the new things we're doing with mechanical ventilation that you always have to be aware of is we want these patients sitting at least a 30 to 45-degree angle. That's going to help not only with your pulmonary edema, it's also going to help prevent aspiration. So there you see the treatment. I love that. There's your sit-up, okay? High flow oxygen, some IV fumosicide, which is your Lasix at that particular point. There's your morphine, and then see what else is going to happen. CPAP, BiPAP are always good. And this was just kind of an interesting picture. It tells you a little how anxiety. Then you can see the alveolar space with the fluid in it and how it affects the rest of the body. And there's your mechanism of cardiogenic pulmonary edema and peripheral edema and heart failure. As you can see, systolic decreased stroke volume. Remember, your stroke volume heart rate tells you about your cardiac output. You're going to have higher than normal end systolic volume. What's going to happen is the fluid is staying in the heart because it has no place to go. There's fluid backing up everywhere else, okay? And it talks a little bit about left heart failure and right heart failure. Re-expansion pulmonary edema, there you see with this one, increased permeability of the pulmonary capillaries as a result of inflammation is going to cause some problems too. So just be aware of that.